Good afternoon and welcome to today's IAC webinar, Assessing the Mechanism of MR by Echocardiography. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like this webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation, and we'll try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select each file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASE CEU credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC Webinars portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I would like to introduce today's guest presenter, Dr. Paul Grayburn. Dr. Grayburn is Medical Director of Non-Invasive Cardiology at Baylor Hamilton Heart and Vascular Hospital and Medical Director for Cardiology Research and Education at Baylor University Medical Center in Dallas, Texas. Dr. Grayburn specializes in cardiac imaging and interventional cardiology with clinical expertise in echocardiography and valvular heart disease, and we're happy to have him with us today. And with that, I will now turn the webinar over to Dr. Grayburn. Doctor?
Thanks, Kelly. Okay, so let me just advance here. We're going to talk about the reason why it's important to assess the mechanism of MR. And actually, it starts with the fact that MR is pretty common. This slide shows you here aortic stenosis on this bottom gray line. This is the prevalence of aortic stenosis in a bunch of epidemiological studies. And then in the gold, you see mitral regurgitation, which is much more common than aortic valve disease. Now, the caveat here is that this is mostly moderate MR and not severe. And aortic stenosis, if it's moderate, will progress to severe. Mitral regurgitation, if it's moderate, may stay moderate for years and years and years. But it's a very common problem that we encounter in the echo lab. So it's important to distinguish primary versus secondary MR. And in my experience, a lot of echo reports don't say anything at all about this. But it's super important because in primary MR, the valve is the problem. We'll get into that. Oftentimes, they're younger patients, maybe in their 50s or 60s or even younger, although they may be older. They tend to have fewer comorbidities. And if you correct the MR by valve repair, it cures the patient. Usually we can repair the valve surgically, and we can do MitraClips when patients are too high risk for surgery. Secondary MR is a totally different situation. The left ventricle is the problem, not the mitral valve. They tend to be older patients, oftentimes with coronary disease, more comorbidities, and it's never been shown that correcting the MR helps the patient. We'll get into that a little bit too. We also know that surgical valve repair has a high recurrence rate, so now surgeons are considering replacing the valve instead of doing a ring annuloplasty. I'll show you the data on that. But a basic overall view of the guidelines is that primary MR should be fixed, and surgical repair is better than a replacement, and a MitraClip is allowed for prohibitive risk surgery. Secondary MR remains an area of uncertainty. There's no proven benefit of surgery in randomized controlled trials. The COAPT trial is underway. You'll be seeing the results of that in September, and that's a trial of MitraClip versus medical therapy. and it's a wide spectrum of disease, and we'll get into that in more detail too. But all of this is sort of a broad view of what the guidelines say. Now, there's a new guidelines that just came out, and it's really a decision pathway on the management of mitral regurgitation. And one of the key components of that pathway is assessing the mechanism of MR. So if you look at this, it's a little bit complex, but you start by identifying the presence of MR up here at the top. There may be symptoms, or there may be a heart murmur, or maybe a transthoracic echo was done. Maybe you did one at your institution, and you identify that MR is present. Once you do that, the next step is to find out, why is it present? What is wrong with the valve that makes it leak? It's not sufficient to say on an echo report there is severe MR. You have to know why. And the reason is, if you know why it leaks and what the mechanism is, you know how to fix it. If you don't know what's wrong, you don't know how to fix it. So we really need to focus on this when we're doing an echo. And sometimes we need to turn the color off and look at the valve and identify what's wrong with it. And we're going to talk specifically not only about primary or secondary or even mixed etiology, where it could be some of both, but we need to talk about the Carpentier classification. And then, of course, we need to determine the severity of MR, and that's very, very important, because if it's a moderate MR, you don't need to do anything about it. And oftentimes, echo labs tend to overcall MR. So we see a lot of patients in our valve clinic where they were told they had severe MR, or we see them and it's actually mild. So this is important, but that's not the focus of today's talk. Anyway, once we do figure out the mechanism and severity, then the heart team evaluates the patients, determines, is it going to be medical therapy? Is it going to be surgery? What kind of surgery? Is it going to be transcatheter treatment, and what kind of transcatheter treatment? And then they come back for follow-up. So that's kind of the basis of why we're doing this. Now, in that same paper, there's this table or algorithm, and it seems complicated, but it's really not. Basically, you want to define leaflet motion using the Carpentier class, and we'll get into that. But type 1 is normal, type 2 is prolapse or flail, type 3, the leaflets are restricted in both systole and diastole, and type 3B, restricted in systole only. So 3 is restricted, but A is both phases of the cardiac cycle, and B is systole only. So you got to define that. And then you've got to determine, are the valve leaflets normal or abnormal? And if you do all of this, this algorithm will tell you whether you're dealing with primary MR, secondary MR due to atrial dilation, secondary MR due to the LV, or in some cases, both. This is the Carpentier classification. And in case you're wondering, about the name, Carpentier is a very famous French cardiothoracic surgeon. He's been in Paris, France, and he introduced the concept of mitral valve repair and has really taught many people around the world how to do that. And in thinking about how to repair a mitral valve, Dr. Carpentier came up with this classification. So again, type 1, the leaflet motion is normal. Type 2, prolapse or flail. Type 3A, they're restricted in systole and diastole. And type 3B, the leaflets open well in diastole, but they can't close in systole, so they're restricted. And if you look a little bit further at this, type 1 is usually going to be endocarditis or a dilated annulus. The leaflets move normally if something's wrong. Type 2 tends to be prolapse almost all the time, can be papillary muscle rupture or trauma. Type 3 is anything that stiffens the leaflets so they can't open and close. And classically, that's rheumatic heart disease, but it can be collagen vascular diseases, radiation, drugs, mitral annular calcium, and other things. And type 3B is a classic ischemic or non-ischemic dilated cardiomyopathy, whereas the heart dilates, it pulls the leaflets apart so they can't close normally. We'll get into that a little bit more. But the reason it's important is shown here, and that is it determines therapy. Remember, we said if you don't know what's wrong, you don't know how to fix it. If you do know what's wrong, you do know how to fix it. Simple. So if you have type 1, it may be chronic atrial fibrillation where the annulus is dilated and the atria are huge. you may be able to treat the AFib, and the MR may go away or get better, or you may need to do an annuloplasty ring. Type 2, you wouldn't want to do an annuloplasty if the leaflet is flail, not going to fix it. So here you want to repair the valve. And this is important. You do not want to replace the valve. It's a contraindication to replace these valves. They should be repaired. You'll see why in a minute. Mitral valve center of excellence is recommended in the guideline. There are very few of these in the country. There's only about 50 of them that are really truly centers of excellence. And the gold standard now has become minimally invasive. That is, you don't get a sternotomy. You get a little thoracotomy on the side. You go home in 3 or 4 days, and you're driving in a week or two. Type 3A, you almost always have to replace it. Repair is rare. And type 3B, we don't know what to do. Guideline-directed medical therapy, revascularization, and cardiac resynchronization may improve the ventricular function and then, as a consequence of that, improve the MR. Surgery has never been proven to be beneficial, although we still do it in some patients. And in terms of surgery, we don't really know whether we should do a ring or a mitral valve replacement. We don't really know about a clip versus transcatheter mitral valve replacement. There are a lot of studies underway. We'll get some answers in the next few years. So I have a question for you, and if we had one of these audience response systems, I would love to see the answer. We don't have that available, but I want you to think in your own mind. This is a parasternal long axis view. Is this mitral valve prolapse? Think in your own mind, yes or no, and we'll get to it. So this is a common situation, and what it is not prolapse. This is a different image. This is actually a transesophageal image, but what you've got, and the same in the previous picture, is you have posterior leaflet restriction right here, where the arrow is. You have anterior leaflet overriding the posterior leaflet, but it does not prolapse because it never comes above the annular line, which is right here. And so basically this is classic secondary MR. It's classic Carpentier 3B. The anterior leaflet overrides the posterior leaflet, but it doesn't come above the annulus. It's not prolapse. And that's a common mistake. So let's go back to primary versus secondary. We're going to start first with primary MR. Blaise Carabello, who's been a friend of mine for 30 years, 30 plus years, famously said, in primary or pure MR, the valve makes the heart sick. And the corollary to that is, if you fix the valve, you fix the heart. So the problem in primary MR is the valve. When you fix it, the heart and the patient get better. And the consequences of primary MR are listed here. So you can have mild primary MR with a regurgitant volume, even moderate, with a regurgitant volume less than 40, and you can tolerate that for years and years and years, and nothing ever happens. But it does impose a volume overload on the left ventricle, which causes eccentric hypertrophy, where sarcomeres are laid down in series. You lose myocytes over time, and you get mitochondrial abnormalities. And so you ultimately get LV dysfunction, LV dilation, and heart failure if you don't treat it. We also know that if you have a flail leaflet with severe MR, that is associated with death in several series, so we want to fix that. We'll get to that in a minute. This is a study that was done a long time ago, 25 years ago, by Mark Starling at University of Michigan, and he looked at normal controls and 3 different groups of MR. And what I want you to focus on is this far right panel, which is insystolic elastance. This is a load-independent measure of LV contractility, and you see that it's about 5 in normals. In MR, it's 2.9 if your EF is normal, and then as it begins to fall, the EF doesn't fall. So remember, we've known this again for years. EF is very tricky in mitral regurgitation because mitral regurgitation augments the EF, and the EF can fool you. You can have an EF of 60 and still have significant myocardial dysfunction, and we'll get to that here on the next series of slides. This is from Maurice Serrano's paper years ago where he looked at valve repair versus valve replacement in the Mayo Clinic. And if you get a valve repair, your survival, shown in blue, is pretty good, and it's equal to what your survival would have been for your age and risk factors had you never had MR. But if you have a valve replacement, you have an early drop in survival due to perioperative mortality, and you don't live as long as you would with a repair or if you never had MR in the first place. So this is one of the reasons why valve repair is recommended over replacement. And again, if you're doing the echo, you need to know, is this valve repairable or is it not repairable? What is the mechanism? Because some mechanisms are repairable, others are not. So you need to show that. Now, in primary MR and mitral valve prolapse, we know that the annulus is saddle-shaped, and you cannot call prolapse unless the leaflets come at least 2 millimeters above the annulus. And remember, I showed you earlier a pseudo-prolapse where it doesn't come at all above the annulus. So remember this paper. It's important, and it helps you diagnose prolapse. We also know, and this is a little off here, but classic prolapse has thick leaflets. It comes 2 millimeters above. Leaflets are more than 5 millimeters. A non-classic, also known as fibroelastic deficiency, the leaflets may or may not be or they are displaced above, but they may not be thickened. They're less than 5. The total frequency of this is almost 2.5% of the U.S. population. Very, very common. What happens is if you have degenerative or primary MR and your EF is above 60, it's normal. If you have any symptoms at all, your survival is really much worse than if you're asymptomatic. So symptoms tell us it's time to operate on a patient. And then what about EF? Well, remember I showed you earlier that you can have an EF above 60 and still have LV dysfunction. If your EF falls to 50 to 60, your survival is markedly worse. Markedly worse. And if your EF is below 50 in primary MR, very terrible long-term prognosis. So that's why the guidelines say we want to operate on people before their EF falls below 60. And now that we can measure global longitudinal strain, we can identify people here who have an EF above 60 but have abnormal LV function. And that's important too. So in this big study from the Mayo Clinic, the things that predicted your survival, or your lack of survival, I should say, were being older, having symptoms, having atrial fibrillation, having coronary disease, or having a low EF. And that low EF in mitral regurgitation is below 60. Again, we're talking about primary MR here. What about Flail leaflet? This is a really interesting study that just came out a couple of years ago. A lot of patients, almost 2,000 patients with Flail leaflets, and notice that 45% were asymptomatic. So it's very common for people to have no symptoms and still have a Flail leaflet. One of the reasons for that is people tend to slow down gradually and almost imperceptibly, and they're not aware of their symptoms. So we often do a stress echo in these people and often find that they really are symptomatic. They just didn't know it because they don't do anything. In these patients, it's uncommon to have coronary disease. Most of them have a posterior leaflet flail, and that's highly repairable. A really good mitral valve surgeon can almost always repair a posterior leaflet flail. And again, notice that the EF tends to be high in Flail leaflet because the regurgitation augments EF. So most of these patients had an EF above 60. Almost none had an EF below 30. And then you see an EF below 45 was even uncommon, only 3%. So in Flail leaflet, you have this survival curve, and this is actually mortality rather than survival. So if your EF is below 45, you have a terrible prognosis. If your EF is above 60, much better. 45 to 60, in between. So EF is important. It's important to note it on the echo, of course. And then also we can tell that from this study that if you had surgery, you did much better than if you had medical therapy. And if you had surgery, you were better off if your LV in systolic diameter was less than 40 millimeters. So we've known this from other studies, but this kind of confirms it. So you really want to operate on these people before their LV dilates, before their LVEF falls. And then it's important to look at LA volumes. So again, in mitral regurgitation, an LA volume index above 60 has a terrible prognosis. So this is another thing that pushes us toward early surgery when we see that the LA is significantly dilated. This is the same data. It just shows cardiac events, not just death, but other cardiac events like hospitalization and atrial fibrillation. So LA volumes are important to measure and report. So again, the guidelines on mitral regurgitation divided into primary and secondary MR, and primary MR goes down this pathway generally towards surgical repair, whereas secondary MR has a different pathway and surgery is not as clear cut. So it's important for us doing an echo to decide, is this primary or is this secondary? What is the exact mechanism of MR? Is it repairable? Does it have to be a replacement? All of this is super important for us to get right. Now, it also asks us in these new guidelines to look at the feasibility of surgical mitral valve repair. And I'm not going to go into great detail here, but in general, an ideal pathoanatomy is posterior leaflet only, minimal calcification of the leaflets in the annulus and the subvalvular apparatus, and the mechanism of MR is prolapse or flail. When you have this, you have a very repairable valve, and it would be a major catastrophe to have to get a replacement when these patients can be repaired. On the other hand, the things that are hard for surgeons to repair would be moderate or severe leaflet calcification, severe mitral annular calcification extending onto the leaflets, diffuse severe thickening of the leaflets with retraction, and then type 3B motion with tethering and an infrabasal aneurysm. So when you're on this side, it's hard to repair. You might have to have a replacement. And in the middle, these are challenging anatomies, but these are things that most good mitral valve surgeons can repair, but most general cardiac surgeons cannot. Again, it's important to identify this on echo so we know, is this a repairable valve, is this not, and who should we send it to get fixed. These are just some examples of that from the O'Gara paper. And you see here thin leaflets with, I don't know how well this shows up on your screens, but the posterior middle scallop is flail here. You can kind of see a little torn cord here and here. So this is flail P2. You see that beautifully on this 3D view here. This is highly repairable, the 98% success rate. In our hands of our surgeons, the mortality rate for this is 0. This is possible. This is a bileaflet prolapse. You actually have some torn cords too. So you have all the scallops of the mitral leaflets are coming up. It's a Barlow's valve. You see that here. 2 torn cords shown here by the yellow arrows and multiple segments prolapsing. Many surgeons cannot repair this. They're going to replace it. But good mitral valve surgeons will always repair this. So this is really important to identify what's going on and get it into the hands of the right person. This bottom picture shows somebody in whom a good surgeon's probably just going to have to replace it. Why? There's a lot of MAC, lots of mitral annular calcium extending down onto the anterior leaflet here. And then you can see that here as well in this bicommisural view. And in the 3D, there's just calcium everywhere, a tiny orifice. This valve kind of has to be replaced. There's not much choice. MitraClip, what about that? You're doing echoes in your lab, and some of these patients are going to want a MitraClip. They've heard about it. Who should get one? Well, the FDA approved it for symptomatic severe MR, which is 3+ or 4+, primary abnormality of the mitral valve apparatus, not secondary, and this is also known as degenerative MR, and they have to be determined at prohibitive risk for mitral valve surgery by a heart team. And that has to include a cardiac surgeon experienced in mitral valve surgery. So that's who the MitraClip is approved for. So again, when we're doing an echo, we have to decide that. The definition of prohibitive risk is really something that's not so much echo. It's a surgical definition, but we see a lot of these patients here that They really have all kinds of these things that make them risky for surgery and then, suitable for a clip. So what is our job as echocardiographers? Well, it's to determine, is it feasible to do a MitraClip? And again, you have ideal features, challenging features, and relative contraindications. And these can all come from the echo. So again, if you're in A2 or P2, the middle scallop of the anterior or posterior leaflet, that's ideal. Ideally, no calcification. You need a mitral valve area of above 4. If you're less than 4, you can get stenosis after a clip, and that's a disaster. You want to have enough length to grasp. You want really normal thickness and mobility of the leaflets. These things called flail width and flail gap are measurable. You can see how wide the flail segment is. The more narrow it is, the better the clip works. And then when you get over here to contraindications, if the body of the leaflet is perforated or has a deep cleft, it may be hard to get a good result. If there's severe calcification at the grasping site, the clip won't stay on or won't even go on. And if you have an area less than 4 centimeters squared, you're going to risk mitral stenosis, especially if there's severe MAC. So again, we have these things that we're asked to look at on the echo to help us know, is this a patient that can get a clip, or is it a patient that should not get a clip? And again, it's not sufficient just to say it's severe MR. We really need to know the mechanism in great detail. So here's some examples of that. Again, P2 is flail here. You see that in the bicommissurial view. You see it in the 3D. It's a narrow segment here. You can put one clip right here where I'm putting the arrow, and this patient should do very, very well. This is something that's more challenging because this is one of my patients, actually, and he was 93 years old, but very active and quite symptomatic, and he had actually a flail P3 and a flail P1. And when you're working in the corners over here, there's a lot of cords that you can get tangled up in. So beginner MitraClips shouldn't be doing this one, but we got clips here and here in this patient. He's still alive and doing great, feels well. He's actually out putting fence posts in around his farm. So he's a tough 93-year-old guy. This is one that's really hard to do. There's a lot of mitral annular calcium, as you can see here, and you see that here. So there's also a very small opening. So if you put clips in here, you're likely to change this person from mitral regurgitation to mitral stenosis, and they're not going to do well. So again, we have to really look at the mechanism in detail. Now let's talk about secondary MR, also known as functional MR. In this case, the leaflets are normal in general. They can have some minor age-related thickening, but it's really not a leaflet problem. It's tethering of the leaflets and annular dilatation by LV dysfunction. Here's how it works. This is from a nice paper in the New England Journal some years ago, where you start off with an infarct. Over hours to days, that infarct expands, and then over days to months, the LV remodels. And as it remodels, you see the cords here, and the papillary muscles get pulled on and displaced outwardly, and it tints the mitral leaflets so that they can't close. This is secondary MR. So here's the mechanism. When you have this is sort of the normal balance between the closing forces. The LV contracts and closes the valve, and the papillary muscles and cords, which provide a counterbalancing tethering force. These forces are balanced in nature, so that when the LV contracts, the leaflets don't get blown up into the LA. They're perfectly closed. But when the heart dilates, as you can see in panel B here, the papillary muscle is displaced outwardly and apically, and the tethering forces overcome the closing forces. The valve can't close, you get MR. This is all well recognized, and we can measure things on echo. We can measure the tinting area, which becomes larger and larger as the leaflets get tinted down into the LV. We can measure the tinting distance, which is the distance from the anterior part of the annulus to the tip of the papillary muscle. And there are many other things. We can measure the angle of the posterior leaflet and the anterior leaflet. But essentially, this is just showing that there's tinting of the leaflets down into the ventricle. Again, here's a simple measurement that some people call tethering distance. There's other terms for this, but we can actually measure this on echo. The annulus becomes distorted as well. This is a normal-shaped annulus. It's D-shaped. It's flat here across the top, round at the bottom. As the heart begins to dilate, the annulus becomes more spherical like this, and it can also be asymmetrically dilated. So we can look at that with 3D echo. We can actually measure the annulus, the area of the annulus, the shape of the annulus. We can measure the tinting of the leaflets and the leaflet lengths. There's a lot of things we can do to really identify the pathology and understand the mechanism. And we did a big study of that where we looked in the STICH trial at all these different measurements, and many of which we found were not significant predictors of outcomes or MR severity. But what was the tinting area. The larger the tinting area, the more the MR, and the larger the annulus diameter in the AP direction, in the LAX view, the more the MR. So those things are probably the most important to measure. Here's just another example I want to show you of somebody who has secondary MR, but their ventricle looks pretty normal. You can see that the ventricular function is not that bad. It's not that dilated. Here is another view. And here you can see that there's an infrabasal or an infra-mid-segment wall motion abnormality with this papillary muscle being tethered. And you see the tethering here, and the posterior leaflet can't close all the way. So this person has secondary MR with a preserved EF. It's kind of interesting. You can see the MR here. There's a lot of MR. We did all the measurements and confirmed that it was severe. And what I want to point out is this person kind of has functional or secondary MR, and they kind of don't. So they do because their EF, although it's 53, their MR is clearly due to tethering of P3, the posterior medial scallop. But although it is secondary, it acts like primary because it's obvious that the symptoms are due to the MR and not the underlying LV dysfunction. This is the thing that gives us fits in the clinic is we have patients that have an EF of 20 and MR, and we don't know which one it is that's making them have heart failure. But in this case, it's not the ejection fraction. It has to be the MR. We see a lot of these patients. Typically an inferior or posterior MI, their EF is preserved, and we know that if they had an EF of 53 and no MR, they would not have heart failure. So we tend to fix these patients, but again, it's important to put all of this on the echo report so that we know what's going on. And this slide just shows the spectrum of LV dysfunction and how complicated this is. If your EF is down here at 10% and you have a 300 ml LV with a spherical geometry, it might be better to treat you with an LVAD or a transplant. You know, it's unlikely that fixing the MR is going to benefit this patient because they're still going to have a terrible LV. On the other hand, if you're over here, like the patient I just showed you with an EF of 60, you know, the heart failure is not due to LV dysfunction. The MR should be corrected even though it's secondary MR. And what we really don't know is where on this spectrum is the patient likely to benefit from MR correction. We still have to do more and more studies and figure this out. So let's just talk about prognosis of secondary MR for a minute. There's a whole bunch of slides. I'm going to go through them really quickly to try to keep us on track here. But this was from the SAVE study, which is an acute MI study. If you have MR, you did much worse than if you didn't have MR. And this is a chronic MR study. It gets quoted a lot from Grigioni, Mayo Clinic. Again, MI without MR did much better than MI, myocardial infarction with MR. So the prognosis is really important here. And this is just showing in that same study that if your ERO by PISA or volumetric technique was above 20 millimeters squared, you did really terribly. So the more MR, the worse. Another study of acute MI from the Cleveland Clinic, 4,000 patients. The more the MR, the worse the prognosis. You know, here's another one from Duke, the more the MR, the worse the prognosis. This is one that I published years ago from the BEST trial, a big heart failure trial. The more the MR, the worse the prognosis. And you can just see this over and over again. Here's an Italian study from Rossi, same thing. The more the MR, the worse the prognosis. So there's lots of data. But what's interesting about this trial, and Blaise Carabello really came up with this, is that if you look at the no MR patients, they had higher EFs and smaller diameters of their ventricle. And as you got to higher degrees of MR, the LV function was worse and it was more dilated. So this throws up a conundrum, which is what is it? Is it the MR or is it the ventricular function? This was the STICH trial, same thing. The more MR you had, the worse the prognosis, but also the worse the ejection fraction and the LV volume index here. Much bigger LVs have more MR. So my fellow Anna Sanino, who's fantastic, published this paper just a few months ago in JAMA Cardiology, where we did a meta-analysis of many, many studies of this. And just to make it short, 53 studies, almost 46,000 patients. And what we learned is secondary MR is a strong marker of adverse outcomes in patients with LV dysfunction. But we don't know why. And here's why. So if you look at this middle line, this is the average or the mean. Patients with no MR had an EF of about 45, mild MR, EF of 40, severe MR, EF down toward 35. This is the opposite of what you expect. We know that MR augments EF, so this curve should go this way, and it goes that way. So the implication here is that the worse the LV dysfunction, the more the MR. And this creates the conundrum of, if you fix the MR but don't fix the LV, have you done the patient any good? So the guidelines weigh in on this, and they basically say, just focus on this blue box, there is no conclusive evidence for superiority of repair or replacement. We really don't know what to do with these patients. This is a study from the University of Michigan in 682 patients with bad LV dysfunction, and they did annuloplasty versus medical therapy, no difference in survival. This is a Cleveland Clinic study, same thing, looking at doing a bypass alone or a bypass plus a ring, no difference in outcomes, whether you looked at death or whether you looked at death plus hospitalization, no difference in outcomes. This is the STICH trial, no difference in outcomes, whether you do just CABG alone or CABG plus mitral therapy or medical therapy, which is just ACE inhibitors, beta blockers, etc. So we don't really have any proof that surgery works here. Now, traditionally, the surgeons have shown this slide, and they've said, well, you know, if you do a rigid ring annuloplasty, you have a low recurrence rate of MR out to 3 years, but if you use a flexible band or an incomplete band, you have a high recurrence rate. And this study was shown a lot. There are all kinds of rings that you can put on. This is the good guys and the bad guys. The white hats are good guys. They're complete rings. They're rigid rings or semi-rigid rings. Incomplete rings or posterior bands are black hats. They're the bad guys. And Craig Miller is a very famous cardiac surgeon at Stanford. He gave me this slide. By the way, he also says, if you don't have a ring named after you, you're not a notable mitral valve surgeon. So the surgeons did this big trial where they looked at secondary MR, and they were looking at doing a ring, versus a replacement rather. And their primary endpoint was LV remodeling. It was powered to look at a 15 ml per meter squared reduction in insystolic volume index. It didn't show that, as you can see here. But what's really important is at 1 year, a third of the patients had recurrent MR if they got a ring, which was rare with a replacement. So now the surgeons are thinking they should replace the valves. And this got worse at 2 years. At 2 years, it was almost 60%. So no difference in mortality statistically. Just go quickly here. So basically, the repair rate was so high in the surgical group that now The guidelines have now said if you have secondary MR, you should consider replacing the valve instead of a ring. So it's complicated. You have to deal with coronary disease, ischemic versus non-ischemic, global versus regional wall motion abnormalities, dilated or non-dilated LVs. Is the annulus normal? Is it symmetric or asymmetric dilation? And even electrical abnormalities come into play. But we can kind of conclude the whole thing that primary MR causes LV dysfunction, heart failure, and death. If you fix the primary MR, the patient gets better. And we know we should repair the valve and not replace it. Echo is key here because we have to say what the mechanism is, and then we have to direct that patient to somebody who can repair the valve. Secondary MR, a different story. Functional or secondary MR is a disease of the left ventricle, not the mitral valve. It causes LV remodeling, heart failure, and death. And if the patient's LV improves, the MR improves. And that can happen with medical therapy, with CABG, with stents, or with CRT. But there's no evidence that surgery improves outcomes, and we're awaiting a big trial that may give us a clue as to whether MitraClip improves outcomes or not. And that's it for me. So we move to the question and answer session.
Okay, thank you. At this time, we'll begin the Q&A session. From IAC Echo, I'd like to introduce our clinical specialists, Sue Jensen and Ann Groves. Sue and Ann will be assisting with the Q&A session today. Sue, would you like to start us off?
Okay, Dr. Grayburn, Amy asked that in the case of asymptomatic patients, is a stress echo required to do surgery?
That's a great question, and it depends. So if they have a Flail leaflet, the guidelines say you can go ahead and do surgery. So it wouldn't be absolutely necessary to do it. I still like to do it because I find more often than not, in fact, in a vast majority, the patients develop symptoms on the treadmill. And I think it helps the patient when they know, oh, I really am symptomatic. I just wasn't aware of it. If they don't have a Flail leaflet and they're asymptomatic, the guidelines say you can wait for symptoms to develop. So in those patients, I do a stress echo to try to figure it out. And the other things, in addition to symptoms, if you saw the PA systolic pressure go way up with exercise, that's an indication for surgery. And sometimes you'll see the MR get worse with exercise. That's also an indication for surgery.
Okay, Wendy asks, if you have to include the Pisa radius for MR fraction calculations, which one do you measure if the patient has more than one jet?
Well, that's a great question. There's never been any validation that multiple Pisas, that we know how to do it. You know, in theory, you could add them together, do both and add them together. But, you know, proof of that is lacking. We tend to measure them both.
Okay. Juan asked if you can assess a MitraClip with Pisa measurements.
Well, so there's some new guidelines coming out probably later this year that recommends that you don't do that. The reason is, and we've kind of shown this, is the MitraClip truncates the Pisa. So if the MitraClip is at a 90-degree angle, it cuts the Pisa in half. So you would have to angle correct the Pisa to get the right measurement. So if you just do Pisa using what's on the machine, it's going to double the true regurgitant volume and the true EROA. So you have to angle correct it if you use it.
Okay, Wendy again here. She wants to know, what are the MR measurements that you use to quantify MR?
We use all the ones that are in the guidelines. We do use, Pisa. We like it, but we recognize its limitations, and we know when it's not accurate. We also use vena contracta. We use volumetric regurgitant volume and fraction. We use pulmonary veins. We use the mitral inflow pattern. And we really also, as we're talking about today, we pay careful attention to the mechanism. Here's something that you really need to think carefully about when you're doing an echo. If you think the MR is severe, but the leaflets are normal, the left atrial size is normal, the left ventricular size is normal, the pulmonary veins are normal, you better rethink it. that can't possibly be severe MR. So it's really important to pay attention to the mechanism and do an integrative approach where you look at everything and put it all together in a cohesive way.
Okay, Maury asks if you suggest universal 3D imaging by our text on a transthoracic echo if there's severe MR.
So we like 3D imaging. In particular, it helps with the volumetric assessment. It's been well shown that 3D volumes are more accurate than 2D volumes because it gets around the foreshortening problem. And provided, of course, you have a decent echo and you can see the endocardial borders. Remember, you can give contrast. So if you get a good 3D volume and you have a good LVOT VTI, you can calculate regurgitant volume more accurately that way. And I think also since LV volumes get bigger over time with MR, 3D is going to give you a much more accurate depiction of how the LV is responding to the MR, how it's responding to treatment of MR, or how much it's causing the MR in the case of secondary MR. So yeah, 3D is very important.
Okay, Kelly asks, how do you quantify MR in patients post-mitral valve clip procedure?
So it's very hard, and it's one of the hardest things that I do. The two hardest things that I do is quantifying MR after a MitraClip and quantifying paravalvular leak after TAVR. The trouble is that the MitraClip is like sticking your thumb over a water hose. It makes a spray. So the color Doppler jet always looks bad, even if there's hardly any MR. And there have been some studies of magnetic resonance imaging showing that people with these big MR jets after a clip have a regurgitant volume of 10 cc's. So we rely much more on pulmonary vein flow, mitral inflow pattern. Remember, an impaired relaxation pattern is almost never seen with severe MR. And so it is challenging. Again, there's a new guidelines. We're working on it right now, and it'll be out hopefully this fall. So I'll refer you to that because it's got a lot more detail in it.
All right. Chandra asks, would you recommend annuloplasty in severe MR secondary to dilated LA from a permanent AFib, Carpentier type 1?
Yes. Thank you for that. It shows you are listening and you get it. That's exactly right. You identify the mechanism, it tells you what to do. So if type 1, Carpentier, it's a dilated annulus, and annuloplasty is the right answer.
Okay, Andrew wants to know, do you incorporate cardiac MRI into your workup? If so, when do you use it?
So it's in the new guidelines that came out last year for assessing valvular regurgitation. We put that in there, and the when becomes more of a clinical decision. But oftentimes it's hard to say for sure whether it's moderate or severe MR, and that's a critical decision point because if it's moderate, you're not going to do anything, and if it's severe, you may need to do surgery. So when you're uncertain about that, an MRI is going to be the referee that makes the decision. The other time you might use it is after a MitraClip, as the previous questioner asked, is when you see a big jet, but everything else indicates it's not a lot of MR, and you want to be sure you can do an MRI there too.
All right. Ronnie asks, when measuring the vena contracta, where should the Nyquist limit be set?
So it should be at 50 to 60, just as it says in the ASE guidelines.
Okay. Kaylee asks, how do you quantify MR in AFib or A-flutter patients?
It's much more difficult, and where we really see this is when we're asked to do a TEE cardioversion in a patient in AFib whose heart rate is going pretty fast, and we'll put the TEE probe down, and sometimes it looks like terrible MR, and then we cardiovert them, and we look again, and the MR is either completely gone or is mild. So I think it's important if you do an echo when a person is in AFib going fast, to try to repeat that echo when their heart rate is controlled or they've been cardioverted, because you wouldn't want to send that patient to mitral valve surgery if it's all secondary to the atrial fibrillation. If the AFib rate is controlled, if their rate is in 60 to 80 and it's relatively regular, the usual criteria for MR work pretty well.
Sonia, going back to stress echo, she just wants to know, using stress echo to figure out MR severity, what parameters do you access pre and post stress?
Well, of course, you want to look at LV function, because there was a nice study years ago that showed if the LV fails to get smaller, that's a bad prognostic sign. You want to look at PA pressure, and you want to look at the severity in general and the duration of MR. One of the things that really tricks people up, and we see this all the time, patients get referred to us because they have late systolic MR and the PISA is big and gives you an ERO of 0.3 or 0.4, and they say they have severe MR. And their left atrial size is normal, and they don't have severe MR. It's just the last 2 frames of systole. They have no MR at all in early systole or mid-systole. I exercise those patients because some of them, the MR stays late systolic during exercise, and you can be assured it's not severe, but in some of them it becomes holosystolic. So you want to look at the duration of MR in addition to those other things.
Thanks again, everyone, and a very special thanks to our presenter, Dr. Paul Grayburn. Please feel free to contact IAC Echo with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC Webinars portal for 3 business days. On the left side of the My Account page, you'll click on Webinars. Look for the title of this session, Assessing the Mechanism of MR by Echocardiography. Beneath this title, you will see the button Attend Event. Click this button, then the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.